Here, give a taste of what I'm throwing out. And we're like, okay. Exams after that. So. Blood and pH ladders, like snake ladders, whatever.
My daughter was, in her younger days, was a catcher. She was a softball catcher, and she started at it very early when I was coaching her, which is really stupid. I don't know why this is not going up there. There we go. Okay, so here we go. Introduction to the digestive system. One of the things we got to do, and I guess maybe the main purpose of the digestive system is for us to obtain nutrients from out in the world, food and stuff we need. We're going to eat it and digest it so that we can both build stuff up. That's called anabolism, A-N-A. You guys have heard of anabolic steroids and things like that to build up things. And then we're also going to eat up things that we can tear down, and that's called catabolism. We're going to burn them up in order to get the energy that we need to function. Easy enough. Catabolic reactions, tearing things down, basically requires two ingredients: oxygen. You can't make fire without oxygen, right? And we need these organic molecules. Now, the organic molecules that we're going to talk about, the things that we call food, are either carbos, fats, or proteins. We will be talking about each of those. Hopefully you remember the structures of those chemicals from chapter 2 in the book that we didn't really cover. We kind of skipped over, but you should have learned it in 112. The digestive tract, called the GI tract, is, or the alimentary canal, is nothing but a muscular tube that goes from your mouth to your anus. Now, let me tell you a little pet peeve that I have, because you guys see all these ads on paper, in the TV and radio and in print, and everything about how you need to flush all these toxins out of your body, right? Toxins. Oh, you better drink this gallon or two of crap and make you poop it all out. You'll clear all these toxins out of your body. All right, now think about this. Anything that's inside your GI tract is not in your body. Anything that's in your GI tract is not in your body. It's just going through. It's traveling through. It's only a toxin if you absorb it into your body, and then it does some damage to you, right? So all of these preparations that do nothing more than give you a lot of toilet time and a lot of diarrhea, really, yeah, they're flushing out your GI tract, but that's not really part of you. Your body hasn't taken it in. It hasn't absorbed it through this membrane that we call them, the membrane, the inner lining of the GI tract. So just keep that in mind. Food goes through your pharynx, esophagus, stomach, small intestine, large intestine, and then out the bottom end. Lots of stuff comes in and does not get absorbed at all. The number one thing that comes in and goes out without being changed in any way is fiber. Right. Fiber. What is fiber? Cellulose. That's right. It's like wood. And I truly do believe that many of the world's problems, and certainly many of the problems that I treated as a surgeon, would have been cured if people ate enough fiber. It lowers your cholesterol, keeps your bowels working regular, keeps you from getting hemorrhoids, keeps you from getting diverticulitis. We know that fiber does a lot of things for you, and most people don't get enough, especially with our processed American diet. And so what I always do is I just take a big scoop or two of Metamucil or one of the fiber products every day. I know all it does is go in at the top and go out at the bottom, but as it goes through, it acts as a sponge. It sucks in a bunch of water. It just keeps everything flowing really nice. Little picture here of the system. We're gonna go through all of these different parts of it. Oral cavity, teeth, tongue, liver. Here's the esophagus coming down here. Gallbladder, pancreas, large intestine. Salivary glands, your spit glands are very important. We'll talk about them. Your pharynx is the cavity back there that carries both air into your lungs, but also food into your esophagus. Stomach, small intestine, and then out the anus at the bottom end. We'll learn about that too. So what are the functions of the GI tract? I think they could be summarized here. Ingestion means you take stuff into your mouth. You start getting it wet, you start getting it crushed up, you bite it, chew it, shear it up. Makes it easier for that stuff to pass its way on down through your esophagus. And if you've ever swallowed a piece of meat that wasn't chewed, you know that that doesn't really work very well. Digestion, chemical digestion, begins in your mouth also. You actually start to break down some of the carbohydrates in your mouth into sugars. And if you want to run a test for that, take a saltine cracker someday when you don't have anything in your mouth, chew it up, and let it just sit there in your mouth for about 5 or 6 or 7 minutes. It'll get nice and soft and goopy, and then it will start to taste sweet. Now, why would a saltine cracker taste sweet? Well, saltine cracker is a starch, but your mouth secretes enzymes from your spit glands that start to break that starch down into individual sugar molecules, and then you can taste them. So that's the beginning of the chemical digestion that goes on. So the chemical digestion continues to break these things down farther and farther as it goes down. Secretion, our digestive system secretes a whole bunch of stuff into itself. The liver makes about 2 liters of fluid a day or so. The pancreas makes a lot. It pours in to mix with the food to help break it up. In addition to the water, it has acids. The stomach makes hydrochloric acid, which is extremely acid. A lot of enzymes are made. Almost every organ going down the way secretes some kind of enzymes to help break down the food. Buffers to neutralize that acid. Salts, and so forth. The epithelium of the digestive tract just secretes a lot of mucus to keep it nice and greasy and soft and keep things sliding through. The digestive system performs absorption. Absorption means bringing the stuff in through the cell walls that need to absorb it, that are on the surface. Bring them into your body, bring them into the cells of the lining of our GI tract, across the digestive epithelium, as it says there. And then excretion. There are certain products that we don't want, and so our body excretes them from those cells into the GI tract so that it can then pass on out at the bottom end. Now, most excretion is done by the urinary system. We excrete most of our body's wastes in our urine, but we do just excrete some of them through our GI tract, and it comes out as part of our poop. The digestive tract is surrounded by a lot of tissues that can't stand the stuff that's inside the GI tract. So anytime you get a perforated bowel, that's not a good deal, because the rest of the body is not made to have the caustic, infected, acidic stuff that's in the inside of your intestines loose out into the other tissues. into the peritoneum and so forth. There's lots of corrosive acids and stuff in there. There's food in there. There's lots of bacteria. We'll talk about the bacteria in your intestine. Much of your intestine is actually sterile, and all the bacteria are gone, but then they reappear in the colon before everything leaves you. Most all of the digestive organs are lined with the serous membrane, and that serous membrane is on the inside. Just below that, there is some connective tissue, a layer of areolar tissue, it says here, and then on the outside of the bowel, there is parietal peritoneum. You remember parietal peritoneum is the outside layer. Peritoneal fluid, the fluid that's in the guts, or in the belly rather, when you open up the abdomen and you look inside at all the intestine, you generally don't find any fluid at all. Maybe there's 2 or 3 cc's in there. You have to look for it. Normally, there's just not a lot of fluid in there. Now, when people are sick, there can be gallons, especially if the body is reacting to some kind of infection. But the peritoneal fluid is just a little bit of fluid. It's secreted by the serous membrane. That's the lining that is the peritoneum. And because there's just this little bit of fluid in there, really all that's in there is to just lubricate things up so that the parietal and the visceral surfaces of the guts can move around in there without friction or irritation. Mesenteries are the double sheets of peritoneal membrane that suspend the guts. And if I could just draw that from the back, say here's the back of your abdomen, and then here's a mesentery coming up, and there's blood vessels running through here, both up and down. This is 2 layers of peritoneum, and then here's a loop of the intestine out here. So this is the intestine right here, and this is the mesentery right here. The mesentery is the thing that comes up from the back, goes up to all the loops of your intestine. You'll see it when you get to lab if you haven't seen that already. And so this is a pretty thin. In it, you can see the blood vessels running up through there. And then here's the intestine. The mesenteries hold the bowel, but they don't hold it still. They allow it to move around some, but yet not go too crazy and not get tied in knots and things like that it would do if the mesenteries were too long. So really the mesenteries are the membrane that comes up here and connects. This is parietal peritoneum out here, right? And this is visceral peritoneum right here on the viscera. And the mesenteries are really what connect those two. You'll see those and so forth in lab much more nicely. That's all I want to say. We'll talk a little bit about the mesenteric development. I mean, how do these things develop back here? Well, the thing you should know is that at the time of birth, or in the early development, let's draw it the way it should be. At the time of birth, before birth actually, if this is a loop of intestine, and this is the peritoneum filling the peritoneal cavity, it used to work out so that we had a mesentery coming up from the back and a mesentery coming in from the front. So this would be called the dorsal mesentery, and this would be called the ventral mesentery. This is obviously the anterior, and this is posterior. The fact is that most all of the ventral mesentery, by the time we are born, has dissolved away and gone away, except for a couple of pieces. Oh, look at that. Yeah, we started out with a dorsal and ventral mesentery. Most of the ventral mesentery disappears. There's a couple of things that persist, and you should be able to identify these on your cats. There's a lesser omentum. The lesser omentum kind of supports the stomach from the front side. And the falciform ligament is a ligament that comes down up here in front that used to hold that old vessel that used to connect when the blood was coming back through the umbilical cord. It would go into the abdomen and turn up, and then it would dive down into the vena cava through a bypass, which was called the ductus venosus, right? The ductus venosus. The ductus venosus scarred off once the umbilical cord was clamped, and once that happened, it turned into the falciform ligament / round ligament, not round ligament, but ligamentum teres, I think, that comes down from the front side. You'll see that on your cats as well. So this is what it looked like. Here's where you had the dorsal mesentery and the ventral mesentery. It pretty much went away, and you're pretty much, by 5 weeks here, you've got the liver, and I'll just leave it at that. The lesser omentum, you should be able to identify in lab. It stabilizes the position of the stomach. It brings the blood vessels into the stomach, and also carries the blood to and from the liver. The falciform ligament is that thing that's kind of between the diaphragm and the liver, helps to stabilize the liver, I guess, but mainly the falciform ligament was that old ductus venosus, or at least the tissues surrounding the old ductus venosus heading in that direction. Hanging off of the front of the stomach, off of the greater curvature of the stomach, is this great big fatty mass called the greater omentum. The greater omentum is like an apron inside the abdomen. We often call it that. It says here it hangs like an apron from the lateral and inferior borders of the stomach. You must look at that. You'll see it. It's pretty obvious in the abdomen. It's mostly just fat. In surgery, we used to call it the policeman of the abdomen. It's this big old wad of fat that just hangs off the stomach, and it would always move to wherever the problem was in your belly. So if you had diverticulitis in your colon, you would find the greater omentum stuck down there to that area, trying to wall it off and contain the infection. If you had appendicitis, the greater omentum would be down there stuck around your appendix, trying to wall that off. Same with your liver and gallbladder. If the problem is up in here, the omentum would kind of move up there to that. So I would just say that you need to be able to identify it, but it's kind of got a nebulous purpose, I guess we could say. The mesentery proper is the main part of the mesentery. It's the main part of this right here that comes up from the dorsal part of the retroperitoneum, basically, and forms the main mesentery. By the main mesentery, I mean the mesentery that goes to the entire bowel, the small intestine, most of the colon, and so forth. It's pretty thick. It's got lots of blood vessels in it that carry blood to the intestine, stabilizes everything, but yet allows a little bit of independent movement so things can kind of move and squirt and push the food along. It suspends all but the first part of the small intestine called the duodenum, and it fuses back posteriorly, which kind of holds everything in place. We'll see it in the lab. We'll talk about it more as we get into the pictures here. The mesocolon is what you might expect. It's the mesentery to the colon, the mesocolon. The colon is sophisticated in humans. Our colon is really divided into 4 or 5 parts. If we were looking at the body from the front, the small intestine dumps down here into the cecum, and this becomes the right colon, or the ascending colon. Comes up here to a flexure, which we call the hepatic flexure, because the liver's living right here. And then it turns, it goes into the transverse colon, and then it comes over here to another corner. We call that the splenic flexure. or the left colon flexure, and that's because the spleen lives right over in here, and then it goes down as the left colon, or the descending colon, and then it makes a loop over here, which is called the sigmoid colon, and then at the bottom down here, it heads straight out. This last 10 centimeters or so of the colon is called the rectum. Now, why would it be called the rectum? What does rect mean? Damn near wrecked him. No, damn near killed him. What? What? It means straight. Yeah, rectum means straight. So you remember the rectus muscles of the eye, superior rectus, lateral rectus, medial rectus. They're straight muscles. Remember the rectus abdominis muscle right here. There's some other rectuses in the body, but basically it means straight. And sure enough, the last piece of our colons are straight and lead right out to the anus. And that's the end of it. So this mesocolon, there's got to be blood coming to this piece of colon. So sure enough, the mesocolon over here, the right mesocolon connects over this way. The transverse mesocolon kind of connects in this way. Descending or left mesocolon connects over here. There's a sigmoid mesocolon, and then that's it. The last part, this rectum down here, is not even in the abdomen. It's retroperitoneal. It goes out of the peritoneum about up here at this level, and it becomes retroperitoneal. Oh, gosh, I just drew that picture and I didn't have to. So anyway, this mesentery right here is called the lesser omentum, and it goes to the lesser curvature of the stomach, which is this side of the stomach over here. This is the greater omentum. This is that big floppy piece of fat that has been cut away in this picture. Normally it would extend down about this far as like an apron, as I said. So here would be the mesentery proper, which goes to the small intestine, the right mesocolon over here, transverse mesocolon here, a left mesocolon over there, sigmoid mesocolon to the sigmoid colon down here, and then the rectum, which goes out. Here's the mesenteries and how they attach in the back. You notice that the right colon mesentery is kind of attached all along there. So the right colon can't really move anywhere. The transverse colon can move some, but it doesn't much because it's kind of on a tether. Left mesocolon holds the left colon right there. Sigmoid colon is kind of floppy and can move. That accounts for an occasional problem with what's called the sigmoid volvulus, where the sigmoid kind of lifts up in here and twists on itself. And that's because it is kind of loose, and when it twists like that, it doesn't get blood supply, and nothing can get through it, so the patient has a bowel obstruction and gets an operation generally. If you look at it from the side, here's those mesenteries coming up from the back. This is where the blood vessels come from the aorta, and they send their veins back in a little different fashion. We'll talk about that later. So here's the backbone. This is all the retroperitoneum back here. This slide is important for a couple things. You need to understand that the rectum is retroperitoneal. See that? It's not floating up here in the peritoneum like all these other loops of bowel. It's retroperitoneal. So is the duodenum. The duodenum is retroperitoneal. That's the first part of the small intestine. And the pancreas. The pancreas is in your back. It's a retroperitoneal structure as well. You probably need to know those three facts, that the pancreas, duodenum, and the rectum are three things in the abdomen that live in the retroperitoneum. Now there's two other organs back there that are shaped like kidney beans that are also retroperitoneal, and they're called kidneys. And they're shaped like kidney beans. Get that? Yes.
section.
Intussusception?
Is that what it's called?
Yeah.
Where like one of the intestines like went
Inside.
like,
Exactly.
it and created like a blockage.
Yeah.
What causes that?
Boy, that's a good question. Let me just draw that for you here. It's a pretty rare thing, but if you had a friend who had one, that's pretty common, isn't it? Intussusception means that the bowel climbed into itself. Usually it's caused by a little polyp, but sometimes in kids it just happens. So if I could draw a piece of intestine right here, and let's just say that there was a little polyp right here on the wall of it, and the bowel is trying to push everything that way, and then what will happen sometimes is it pushes this polyp on down. So then what happens is you've got the polyp hanging. Let's make it go this way. And it kind of sucks the bowel into the bowel and keeps pulling it on down there like that until it gets to the point where it's way down in there. And now this area gets all swollen and nothing can get through, and so it's obstructed. And usually you can do two things with it. Sometimes you can just go in and actually pull it out with your hands, and then maybe put a couple stitches in to keep it from doing that again. But usually what we would do is just take and resect it, take that piece out and put it back together, and it wouldn't happen again. Let's go to lab. We're kind of late. Intussusception. I don't think that's mentioned in our book, but it's a good question.
Yeah, she looked like 30.
30?
And just presented with like a little pain.
Yep.
So I'd be dilated, and then all of a sudden
Nothing.
And then waited a couple of days and finally went in. They did a contrast CT for abdomen and found that there was like a blockage, but they
Right.
couldn't really see like a huge blockage.
Yeah.
So they